Hello, and welcome to today's webinar presentation, CANCOV Study, the Impact of COVID-19 on Lung Health. And we have two distinguished presenters today, Dr. Angela Cheung and Dr. Margaret Herridge. Dr. Cheung is a clinician scientist at the University Health Network, senior scientist at Toronto General Hospital Research Institute, and professor of medicine at the University of Toronto. She currently serves as KY and Betty Ho Chair in Integrative Medicine and Director of Center of Excellence in Skeletal Health Assessments at the University of Toronto. Dr. Margaret Herridge is a senior scientist at Toronto General Hospital Research Institute, University Health Network, and Professor of Medicine at the University of Toronto. Thank you both, doctors, for presenting today, and Dr. Angela Cheung will be starting.
Sure. I just want to thank you for that introduction, Sharon, and thank you for inviting me and Dr. Herridge to join you all. We're here, Dr. Herridge and I are here to represent the CANCOV group of investigators. And that CANCOV is a cohort study, longitudinal cohort study with 1 year follow-up. We're trying to extend it to 2 years. And we are recruiting patients from British Columbia, Alberta, Manitoba, Ontario, and Quebec in multiple centers. And we try to recruit not only patients who are in academic centers, but also in community hospitals as well. And so we split the cohort into those who are hospitalized in the hospital, meaning in the acute care or in the ICU, and those who were not hospitalized. And we wanted to include caregivers because we know how when someone is unwell, that the family caregivers is also affected as well. These are the co-PIs or co-principal investigators, and it's a project that we are doing in collaboration with the Critical Care Network in terms of, as well as the Internal Medicine Network as well. And we wanted to provide a platform for patient-centered kind of study, where we are collecting clinical data, research data, and biospecimen. And we are partnering with multiple people to look at the host genetics and also multi-omic studies. And we also try to sequence the virus as well. So the overall objectives of the study are to determine the short and long-term outcomes of patients with COVID-19 and their caregivers in Canada, and also to examine the social, demographic, clinical, and multi-omic predictors of these outcomes. So what we have been doing is, see people at baseline and 7 days, a month, 3 months, 6 months, and 12 months from their acute infection. And we collect data on what kind of other illness that they have, medications, what they do for their primary daily activity, their work status, their symptoms, their quality of life, mental health, resilience and stigma, complications, as well as nutritional status. And we also try to, we see patients in person if possible, and we do physical examination and we test their function, and we look at their healthcare utilization and reintegration to normal living. So this is a diagram of all the various pieces, the partners for this study platform. So the purple ones are the ones doing the blood analyses. So there's CANCOV doing serological, like antibody data. There's beacons that look at the the coagulation and endothelial function issue, and cyclic is looking at complements, and we have imaging study looking at the brain and also cardiac MRI, and we have many other pieces, including a muscle study called ICU Mend. So I just want to give you an update. As of half an hour ago, actually this is a typo here, but the total enrollment, so not just Ontario, is 1692. There are 425 in the cohort that are not tested at the acute phase of the infection, but they complain of symptoms consistent with COVID. And so we call it a screening cohort. We also have 629 patients in the non-hospitalized cohort, 283 in the hospitalized non-ICU cohort with 11 caregivers, and 287 in the ICU cohort with 57 caregivers. I think you have all heard of that. Yes, COVID-19 is a respiratory virus, but it can affect many other things in terms of different symptoms, such as your heart, the endocrine system, your skin, the kidneys, the liver, the GI tract, and also neurological. The most common complaints are fatigue, shortness of breath, brain fog, insomnia, and a fast heart rate. This is a systematic review looking at the long-term effects, and you can see that fatigue comes up as one of the higher percentages, but you can see that they have many other things as well. And you can see the cough is 19%, and dyspnea or shortness of breath is 24%. And so, you know, there is even some report of pulmonary fibrosis at about 5%. So some people call, you know, that this long COVID or post-COVID condition, which is the WHO sort of terminology, the post-pandemic pandemic. Now, there are many terms for post-COVID condition that you may see. Post-acute sequelae of COVID-19 or PASC, long COVID, long haul COVID, or some people call the patients who are affected as long haulers, post-acute COVID syndrome, chronic COVID, as well as long-term effects of COVID-19. Now, we've been working with PHAC, that's the Public Health Agency of Canada, to do a living systematic review on the prevalence of symptoms, sequelae, and difficulties conducting usual activities. And if you take long-term, which is really the definition WHO came up with last week, more than 3 months, fatigue is definitely the top ranking one. Shortness of breath are sort of in this kind of range, in the 20-something% range. Although it's higher in the short term, like 38% here, you can see. But as you can see here, there are many different symptoms. There are actually more than 100 symptoms that have been in the literature. And cognitive impairment or difficulty concentrating or impaired executive function is a common complaint. And also sort of muscle pain, joint pain, and you know, having a fast heart rate, those are often common complaints as well. What is amazing is that in terms of longer term, meaning 3 months or more, there's about 9% of patients, according to the literature, that actually have trouble going back to work. So I want to show you some data from our CANCOV study, and this is really work in progress. And so I would not say that this is the final word on this data, but I want to just give you an idea of the study. So I mentioned to you sort of across the different cohorts. And, you know, these numbers are not the same as what I told you because these numbers are constantly changing and there's data cleaning and all sorts of things happening as well. So it's work in progress. But one thing we can see is that there are more women than men in the non-hospitalized group, whereas there's more men than women in the hospitalized cohorts, whether it's ICU or not ICU. And average age is in the 40s for the non-hospitalized group. And the hospitalized group is in the 50s. And so some people think, oh, it's only the really old people who get hospitalized. That's not true. And you can also see the racialized populations in the hospitalized group as well. That Caucasian is 71, 72% in the non-hospitalized group, whereas it's between 46 and 50-something% in the hospitalized groups. So what I'm going to concentrate on is a discussion of the non-ICU groups. So non-hospitalized or hospitalized, but didn't get into the ICU. And so when we actually look at this population, what are their symptoms? You can see that fatigue is a big one across the board. Shortness of breath or dyspnea is 30-something%. So you have to take this with a bit of grain of salt at the 12 months because not everyone has reached the 12 months yet. And cough. So cough really decreased over time from 30-something% to about 15% at 3 and 6 months. These are some of the things that I thought you might be interested in. When we do 6-minute walk, so that's walking someone for 6 minutes, you can see that patients do improve. So the non-hospitalized group start off with better than being hospitalized. And again, I'm not talking about the ICU group. At 1 month, 3 months, 6 months, and 12 months. So you can see that the hospitalized non-ICU group actually make improvement over time to 12 months. And actually the non-hospitalized group too, just that the improvement is not as big in terms of the hospitalized group. But what is interesting is that even at 12 months, they're not really back to sort of the average, which is 100 here. So those are some interesting things. Clinically, what do I see? So I've been looking after patients since 2020, since March of 2020. One of the most common diagnoses that we make is hypertension or high blood pressure. There are patients who resemble myalgic encephalitis and chronic fatigue syndrome. There is an episodic nature to the illness where patients may feel better, and then when they go back to work full time, they feel relapses. So there are episodic nature of this condition, the long COVID condition, or the post-COVID condition. Similar to post-exertional malaise in the ME/CFS literature. We do diagnose patients with POTS, or what's called postural orthostatic tachycardia syndrome. There are patients with shortness of breath, especially with exertion. And there are people who have dysautonomia, and some patients have seizures and tremors and myoclonus. We have picked out a couple of malignancies as well, but I don't think that they are related. And we have a whole bunch of skin findings as well. So I want to show you this family who thought they got COVID, but never got tested in the early days because of limited resources in Ontario. And what happened is that the index case is actually on the left. So this is a brother who was studying at U of T, University of Toronto, and he got COVID toes, as you can sort of see visually. He gave it to his girlfriend, he gave it to his mother, he gave it to his brother on the right. And both himself and his girlfriend and his mother tested positive for COVID antibodies, meaning they were exposed previously, even though their nasal swab PCR test was negative by the time that they actually got around to testing for it. But the brother was tested negative for antibodies. And actually, this younger brother had the most severe case with COVID toes that persisted a long time. Now it's treated and doing better, but he also had seizures as well. So one of the things earlier in the year was patients were feeling that they're ignored and that they get doubted and dismissed because they didn't have the PCR positive test. And last week, WHO, for the case definition of post-COVID condition, actually included the people who never got tested and didn't test positive for it. I know for this group, you're interested in respiratory problems. And so what I can say is that I can speak for the non-ICU groups of patients. And if you look at those without any prior respiratory problems, shortness of breath is common, especially initially, but does improve with breathing exercises. Coughing and wheezing are also common initially, but they also get improved with steroid inhalers. Often the oxygen saturation with the 6-minute walk test is normal. And chest x-rays by 3 months look normal as well. And for those that we have done pulmonary function tests or oscillometry, it's consistent with weak respiratory muscles rather than a lung issue. And so we do teach patients breathing exercises. I can say that of all the patients I've treated who were not in the ICU and who didn't have a prior respiratory problem, none requires oxygen at 3 months. And so, why do I say without prior respiratory problems? Well, we have patients with chronic obstructive pulmonary disease. We have patients with cystic fibrosis who have had 3 lung transplants. And so those patients are a bit different. So of the patients who did not have a prior respiratory problem and were not in the ICU, we have not diagnosed pulmonary fibrosis as a result of COVID-19. So with that, I'm going to pass it on to Dr. Herridge to talk about the ICU group.
Sorry, Dr. Herridge, you're muted.
Thanks so much. And can you see my screen there?
Yes.
Great. Okay. So thanks again, Sharon, for the kind invitation to chat with the group here. And I'm a respirologist and a critical care physician, and I'm going to focus my comments more on the ICU group and review some of the literature that's evolving in the critical care group world literature, as this is really quite consistent with what we're finding in CANCOV. So I just wanted to say that I don't have any conflicts of interest to declare, and I have no relationship with industry, just to clarify that. And I'm just going to talk to you briefly about those things, and also a few lessons learned from SARS. We also did a one-year study of SARS patients and their caregivers many years ago after the SARS 2003 outbreak. Just to remind everybody, and Angela, Dr. Cheung already spoke a bit about this, that the SARS-CoV-2 virus uses the SARS-CoV receptor ACE2. And the ACE2 receptors are really expressed all over the body. So we really have a multi-system organ disease. And its course really starts out as an initial early infection and progresses to often pulmonary abnormalities, these ground glass opacifications that are shown and evident on chest X-ray. This can then develop and evolve into a multi-system and often very severe host response and hyperinflammatory response. And this is a diagram from early on in the first wave. I think the subsequent waves, including the Delta variant recently, this time course was a little bit accelerated. I won't recapitulate some of what Angela's shown in her talk, but basically we're talking about a multi-system disease. So Angela and I looked at survivors of ARDS, very severe lung injury, and looked at these folks up to 5 years after their ICU discharge. Similarly, my PhD student, Kathy Tansey, looked with our group at one-year outcomes in SARS. And I will just say that both in the SARS patients, most of whom were not critically ill, but also in our acute respiratory distress syndrome group, the patients at early on had some pulmonary dysfunction, but really by 6 to 12 months, patients did not have important pulmonary issues. Now, the issue here that I'm showing you is the distance walked in 6 minutes, where the SARS patients did have a bit of a decrement in functional outcome, and the ARDS patients even more so, because they had developed ICU-acquired weakness, which is a muscle and a nerve injury associated with severe critical illness and a prolonged stay in the ICU. And here's the pulmonary function data that I mentioned, where patients were achieving normal or near normal pulmonary function by 6 to 12 months after their hospital or ICU discharge. One of the major persistent complaints in the critically ill patients is that of muscle weakness and fatigue. And in the critically ill patients, I just wanted to briefly highlight that these patients almost certainly have the ICU-acquired weakness. This is a myopathy, a muscle injury that's very specific to critical illness, and also an axonopathy or injury to the axons in the nerves. So the patients will have both a nerve and a muscle injury, and this results in weakness and functional disability. And this can be captured as distance walked in 6 minutes or other functional outcome measures that vary across studies. Because critically ill patients have a lot of exposures to things that have their own consequences, a lot of iatrogenesis, because they do spend a lot of time in the ICU. We certainly see many problems in the post-ARDS patients. They will tend to have cognitive dysfunction on the order of mild Alzheimer type dementia and moderate traumatic brain injury. And this occurs across all age groups, not just older age groups, but young patients too. The patients will tend to have mood disorders, anxiety, depression, post-traumatic stress disorder, and many of the features that have been previously described, not only in ARDS, but this post-sepsis syndrome, the syndrome of chronic critical illness, many overlapping features that were also articulated most recently in the post-intensive care syndrome, issues of frailty, and also issues of very many multimorbidities, things like pressure injuries, contractures, complex issues related to a long and complex ICU length of stay. So with that in mind and that background on ARDS patients, which is really what the COVID patients develop, they develop pneumonia and this progressed to a very severe lung injury syndrome like ARDS. This is the reason to show you that background. So this is the initial clinical description of COVID in Wuhan. And you can see the patients were young. Only 5% went to the ICU. A lot of patients had radiology abnormalities, and the lymphocyte count in this group tended to be low. In this early Italian study, you can see that after COVID in follow-up, many patients continued to have persistent symptoms, as Dr. Cheung outlined, including fatigue, dyspnea, shortness of breath, joint pain, chest pain, etc. And these symptoms have continued to be very robust. We know across the international literature, and this is data from a study from Brazil by ICU colleagues of mine there, that COVID tended to affect patients with greater burden of comorbid illness. So those patients who had more pre-existing health issues had more difficulties. Patients who tended to be less educated or who were in lower socioeconomic groups also tended to be more vulnerable. Racialized groups also tended to be more vulnerable. And we definitely see that in other international studies. And COVID has really shone a light on health inequity in general across international health systems. These are American data from 68-day outcomes. In the critically ill patients, we can see that many patients were rehospitalized. Many patients were readmitted. Some patients were readmitted to the ICU. The point of this slide is really to show you the emotional impact of having COVID and having been hospitalized. Patients had enormous emotional impact, and also a very important financial loss and financial impact. So this illness was having very important effects on multiple domains of that person's life. These are 4-month outcomes from the French comeback study. And I just want to point your attention here, since I'm talking about the ICU group here, the intubated patients, and you can see that these patients also had shortness of breath. A smaller number had a persistent cough. An important percentage had lower than normal distance walked in 6 minutes. And even at 4 months, the majority, 76% almost, had an abnormal lung scan. And most of this was ground glass opacifications. And those ground glass changes do not necessarily evolve to fibrosis, but they can. And in this particular study, they were already beginning to see some fibrotic changes here, 37% of patients. The pulmonary function abnormalities were modest here, but still present. And you can see here that these patients did have cognitive complaints, symptoms of anxiety, symptoms of depression, problems with insomnia, and symptoms of PTSD. And these would be consistent with the prevalence in post-ARDS patients. The 6-month data were published by the Wuhan group. And you can see here in the scale 5 to 6, these are the critically ill patients. And again, and the reason why I was showing you the background literature on ARDS, that a very high proportion of patients here at 6 months continue to report fatigue or muscle weakness, sleep difficulties, alopecia or hair loss, and continue to have anosmia or smell dysfunction, and some cardiac issues related to palpitations. So still 6 months out, a lot of symptoms in the post-critically ill group. And again, some challenges with mobility, persistent pain or discomfort, anxiety or depression. So the mood disorders again remain prevalent, a reduction in quality of life, and an important proportion of patients still who had a lower than normal limit in the normal range of the projected 6-minute walk distance. Another important finding here is that, and I mentioned, and so did Dr. Cheung, that the ACE2 receptors are throughout all of the organ system, or throughout many organ systems, but these patients had a decrease in their kidney function after critical illness. They weren't necessarily on dialysis, but they had acquired this loss of reserve in their kidneys. These patients, again, pointing you to the critical care group, they continue to have some pulmonary abnormalities at 6 months, and they continue to have radiographic abnormalities, most commonly ground glass opacifications. Now, the one-year outcomes have been published by the Wuhan group. This is the leader of this group has been Cao. And I would say that all of these abnormalities at 6 months had some improvement, but incomplete. And the most persistent issues were really related to weakness, decrease in distance walked in 6 minutes, and some challenges as a result of this with return to work. So here's a table on work status at 12-month follow-up. And you can see here that the majority of people returned to their original work, but almost a quarter of people did not return to their pre-COVID-19 level of work. So their job was the same, but the amount of work they were actually doing, the amount of responsibility in their work was quite different for about a quarter of the patient at 1 year, quarter of the patients at 1 year. And you'll see here that the most common reason for this was a decrease in physical function, and related almost certainly to some of the data I've already shown you. Angela and I both participated in the science table, the advisory for Ontario, and there's no question that the patients continue in Ontario to have a lot of symptoms, the post-ICU patients and many of the general internal medicine patients. And many of the patients in the community not only are symptomatic, but have had challenges with ongoing decreased function, cognition, mood disorders, and this has led to difficulties with return to work and other activities of daily living. So this represents a very important challenge for the province of Ontario. And Angela showed you the WHO data as well. So this is a very important issue, the post-COVID-19 condition, and will really represent that second wave of illness now that COVID-19 is beginning to subside. I just offer this reference here. This gives a lot of information about mechanism, perhaps not the focus of the talk today, but some of the mechanistic issues related to COVID-19 infection and some of the persistent symptoms. There's an emerging rehabilitation literature in COVID-19. This is really a multi-dimensional approach. This particular paper focuses on the physiatrist or the rehab specialist being sort of the hub of the wheel, and helping to coordinate cognitive rehab, psychological rehab, and addressing various medical issues that are part of that as well. I know Angela already acknowledged all of our partners. It's a very large national study. If anyone would like to get in touch with us or even join at this point to the study, you're very welcome to. We can be reached in all of these different ways. And I guess my final thoughts would be that it's important to remember that COVID's a multi-system disease. We're still understanding the long-term sequelae or outcomes. We have applied for funding to extend CANCOV to 2-year follow-up. And we hope to contribute some of these longer-term observations. These are essential for to understand healthcare utilization for public health policy and healthcare planning. We're certainly seeing some similarities, but also some differences with SARS, with our critically ill patient population with ARDS. And Angela mentioned some of these other issues. We're doing a lot of translational work to also try to contribute to the mechanistic understanding of this. Early rehab and Dr. Cheung is leading an early rehab study, the RECLAIM study. She may wish to talk about that, really focused on multisystem morbidities. Our own recover group is focused on the multidimensional rehab in post-ICU patients, and happy to talk about that as well. So I'll end there, and thank you so much again for the kind invitation to speak, and happy to entertain any questions. Thank you.
Thank you, Dr. Herridge and Dr. Cheung. We have received some questions, which I will ask both of you. And I also say to our audience, if you have questions, if you can enter in a Q&A, I'd be more than happy to facilitate the discussion. So the first question that we had sent in advance, several people had asked, you know, they've been informed that episodes of fibrosis can be triggered by a virus. What is the evidence that COVID-19 might do this?
Well, maybe I'll start, and then Dr. Cheung could follow up on that. I think that maybe two comments. I think the data are still emerging, how closely linked the COVID-19 infection is to the subsequent development of pulmonary fibrosis in patients who did not have any pre-existing lung disease. I would say anecdotally that at least in the most severe, the patients most severely affected by COVID-19, and these are the critically ill patients, we have seen some pulmonary fibrosis in these patients, but not in everyone. And some of these patients have also other types of lung diseases because they've had recurrent severe infections in the ICU. And this doesn't just cause fibrosis, this can also cause injury to the airways, something called bronchiectasis. So when we see patients, at least the post-ICU patients in follow-up, there are many patients who have had a complete pulmonary recovery. There are some patients who do seem to have some residual structural lung disease. That's not so much fibrosis necessarily in isolation, but fibrosis and bronchiectasis, because they were complex, critically ill patients. And I think we are, as Dr. Cheung has shown you, we're still doing some preliminary analyses of our data set, and we hope to share those data. But I would say at this point, definitely the people without pre-existing lung disease, there was a varied pulmonary response in the critically ill group to COVID-19. And I don't know if Dr. Cheung wanted to make some comments to that or as well.
I think Dr. Herridge is actually the respirologist here. I'm a internal medicine acute care person, but not a respirologist. So with that in mind, I would say that for the non-ICU group, patients do not have a problem with oxygenation. They may feel short of breath and feel deconditioned, and which is a bit different, you know, and we have certainly not diagnosed any pulmonary fibrosis in patients who were well without any lung disease before. Now, we do have really unwell people. We have, you know, someone, as I mentioned, like with a history of cystic fibrosis. We have actually several with a history of cystic fibrosis and 3 lung transplant or 2 lung transplants. Like those, I do think of in a different category because they have all sorts of, you know, recurrent infections. So is it possible that pulmonary fibrosis can be triggered? I always say anything is possible, but is it likely? And I think if you are not that ill, it is not that likely in terms of triggering pulmonary fibrosis.
Okay.
I see, pardon me, Sharon, but I just see some of the comments here from patients who have ILD as an underlying condition. Yeah. And concerns. Yeah, so, you know, I think also there isn't a lot of data to guide on that, but there's no question that patients with underlying lung disease may be more susceptible to COVID-19 just because, and sort of getting sicker because they just come to the illness with less reserve. Similarly, patients with cardiac disease, because COVID is a multisystem disease, or pre-existing kidney failure, it's a vulnerable organ already, and patients may have more serious disease because we know that patients with pre-existing comorbidities have more challenges. So I wouldn't, how to quantify that risk. I think there's no literature to really guide us on that. Would you be at more risk? I think so, as anyone would who's, got comorbid illness. It's great to be doubly vaccinated. I think if you're on any kind of immunosuppression therapy, you would want to strongly consider having a third vaccine. The organ transplant patients are now being formally recommended to receive a third vaccine, and many other groups who are formally immunosuppressed. So this might be something for the folks with ILD on the chat here, that if you are on immunosuppression therapy, that's something that you may want to strongly consider and seek more information about. That's already underway, that strategy in Ontario for certain groups.
And I agree with Dr. Herridge, and I would like to add that, vaccination, yes, it does protect against COVID-19, but it's not perfect. And so until this pandemic is over, like I would still take the other precautions, like wearing a mask in indoor settings. And yes, I know it's opening up, but I always get a bit concerned when, there's still, 4,000 cases a week in Ontario. That's new, right? So I think until the pandemic is over, you should take the precautions, like everything else. Like if someone has heart disease, it's not that we just treat their high blood pressure. We try to look after their diabetes and make sure there's not smoking, and make sure the cholesterol is good and everything else as well. So in a similar manner, would really suggest that you take other precautions.
Okay, we have a question in the Q&A. Someone wanted to know that, their mother and two half-brothers passed away due to PF. And they're wondering, does that mean they should be more concerned about catching COVID? They do try to avoid outside crowds and everything, and they work outdoors with minimal people and always wearing a mask. But are they still, more vulnerable to COVID?
Well, I think that it's, well, again, I don't think there's any literature to guide us on this. And I think any one individual's susceptibility is really, it's hard to gauge. I would just say though that if you had a family, given that you have a family history and this is a clear vulnerability within your family, I would be very, I would definitely strongly endorse being fully vaccinated, and strongly endorse what Dr. Cheung said. I mean, taking those precautions, wearing a mask indoors, or in situations where you're going to be in close contact with people and might share aerosol in particular. I would just be very conservative. I have to say that, I wear a mask indoors myself because, as Dr. Cheung was saying, the double vaccination is helpful, but it's not wholly protective. And this is a very important thing that's, to just discuss, that it's a preventative and protective measure, but we can still see some people break through. And you really want to be mindful of that. And in particular, if you're in a very vulnerable group, or perhaps if you live with people who are vulnerable, if you live with people who are immunocompromised, or who have a lot of burden of comorbid disease, you, I think, would be well served to be very conservative and cautious yourself, because the double vaccination is going to mitigate risk, but not completely remove risk. And I'd welcome Dr. Cheung's comments on that as well.
Yeah, for sure. Unfortunately, with this whole pandemic, I've really met patients who have lost their brother, their mother, their father, they're the only sole survivor in the household, right? So I think it's important for all of us to take precautions and be safe and not do sort of high risk activities.
Okay. Someone wanted to know for both of you, for those who had COVID but did not have pre-existing lung diseases and didn't go to the hospital during their COVID illness, but ended up with serious shortness of breath, has anyone recovered from that? Like, do you think these folks can recover from their COVID condition?
Did you want to go first, Angela?
Yeah, so I can talk a little bit about that. I've seen many who have recovered, but it is really important to rest and pace yourself. So don't overdo things. We always say, keep it under the threshold. So if you are doing too much, then you may have sort of a relapse of your symptoms, including shortness of breath. And sometimes it's not that obvious to the patient because they look at, what have I done today? And I'm feeling this way. So often it's not just what they did that day, but actually the preceding few days. And so resting and pacing is really important. And yes, I have seen patients recover.
Good.
Yeah, and I think that even for many of the ICU patients, their trajectory of recovery is a little bit slower. The recovery may go on beyond a year, but I think most patients are continuing to have incremental recovery. Will they be left with maybe some, decrement in their function, like they're not exactly who they used to be? It's possible, but we have some patients who tell me that they are functioning exactly as they were previously, who were critically ill. So there is quite a lot of variability.
Okay.
And I would add that doing slow breathing exercises do help. And so this is, you don't want to overdo it, but can do 10 in the morning and 10 at night before you go to bed. Just take deep breaths, and it doesn't matter whether it's through your nose or mouth, and try to expand your chest and your lungs and fill it with air. And then slowly try to release it as well. I always tell people at the peak of your sort of inspiration, you want to take a little bit more to expand it. And patients will say, oh, it hurts, and the complaint of chest pain, it's okay. And then if you do this, so I've had patients who come back to tell me they've been doing this and listen to this, and actually their breathing is better. So I would encourage you to try.
Okay, thank you. We have another patient who has scoliosis and restrictive lung disease. They're fully vaccinated, but they've been advised not to return to work yet. What are your thoughts on that? Because they're very concerned about breakthrough cases.
Yeah, well, again, I might just reiterate that your baseline health, or your baseline, in this case, lung reserve or pulmonary reserve, has a lot to do with how you're going to interact or develop complications from COVID-19. I think someone with scoliosis or kyphoscoliosis who already has restrictive disease, but it's on the basis of their sort of skeletal changes and their skeletal sort of morphology, they will be at more risk from COVID-19 as well. They again have less lung reserve, less pulmonary capacity and pulmonary reserve. So I think when you compound that with COVID-19 lung infection, that's then going to affect the lung tissue itself, I think that could lead to someone decompensating. So I would say that it would be very appropriate to be cautious. I don't know if that patient's on home oxygen or this is someone who's on nocturnal, non-invasive ventilation. But if their restrictive disease has extended to that place, they would be a very vulnerable patient. And I think that's probably wise to be very cautious about a lot of exposures in an indoor environment where the risk of aerosol spread is obviously much higher. I don't know if Dr. Cheung wanted to comment on that as well.
Yeah, I totally agree. And I think it really depends on the patient situation in terms of work as well. Are they working alone in an area, or are they, in front of, working at a grocery store? So the filter or ventilation is really important as well in the workplace. We saw sort of how there have been outbreaks in, like even in Amazon, like factories and other places, right? So I think it really depends on that patient's personal situation as well as the work environment as well.
Okay. Both of you had mentioned about the booster vaccination. So someone wanted to know, when do you think people with underlying lung health condition will be eligible for a booster shot?
I personally don't have any information about when the government's going to move to, roll that out in a more systematic way for this group of patients. I expect it will happen, but I don't have any information on that. I don't know if Dr. Cheung does.
I don't either. There are experts who sit on that at that table to discuss when. And all vaccinations are controlled, centrally, right? So it's not like we can just like prescribe it per se. But I would say for those with lung issues, it's also important, like as things are opening up, to think about the flu vaccine as well. We can only imagine if someone gets flu and COVID, how bad it can be.
Okay, so that was the next question.
Yeah, thanks, Angela, for saying that. Yeah,
should they be getting a flu shot as well?
100%.
Okay.
100%. We will be. We do every year.
Yeah.
Absolutely. Influenza, influenza brings people into hospital and into the ICU. It doesn't, not in the numbers that COVID has, not with the impact that COVID has had, but people get very sick and they die from influenza as well. So definitely get vaccinated this year, every year.
Okay.
Yeah. So last year, I think I got the flu vaccine around this time of the year, and then I got COVID vaccine in December and then January. So and plan to sort of do flu vaccine again. Yeah.
Okay, thank you. Someone wanted to know, if they contract COVID-19, will it cause their LID to progress, or do you, if you survive it, or are you able to return to your current status, or will that progress their disease?
Again, I think, we'll be watching the data on this emerge. This question will be answered. There are a number of studies ongoing. We may have some insight into that in CANCOV as well. I think that one might suspect that it would really aggravate the interstitial lung disease. I think it's, as I say, that's an opinion-based comment. That's not based in data yet. But I think with that underlying vulnerability and sort of a COVID-19 superinfection, I think it's very possible that it could aggravate ILD. And I think it would make it unlikely that people would return to their prior functional status. It will, in some way, whether it's because of muscle weakness, And that makes it harder to breathe, which could just be that their diaphragm or their respiratory muscles are weak, and it's a cause of shortness of breath. Whether it's because of the persistent cough is very disruptive. And that's a very long-term symptom of COVID, reported in the Wuhan one-year paper. Still a lot of people with that symptom, and same in CANCOV. I think there are a number of reasons why people may be more symptomatic and not return to baseline status. And I would be concerned about that. Yeah.
Someone also wanted to ask, they've been fully vaccinated, but their young adult children don't believe they need to because they're young, they're healthy. They're not sure how to persuade them to, go get vaccinated. What would you say? What's the advice? Like, are they vulnerable?
Yes, I think they're vulnerable. As you can see from our age in the CANCOV cohort, it's been dropping. The first wave, we have older people. Second wave, a little bit younger. Third wave, a little bit younger. And currently this wave is quite young. So you don't need comorbidities to get it really sick to be in the hospital. Yeah, and maybe Dr. Herridge can comment on that too.
Yeah, I mean, I would just say I just came off clinical service in the ICU yesterday at I work at the Toronto General, and all of the critically ill COVID patients I'm currently looking after are patients who are unvaccinated. Maybe one person was immunocompromised through, a lot of immunosuppressive medications, but most of the patients were unvaccinated patients, and these were patients in their 20s and 30s. This is a very real issue, and we are losing patients in their 20s and 30s. They are dying. So I cannot imagine why anyone would want to take this risk. I can't imagine.
Okay, thank you. Someone also wanted to know, one of the hesitations of some people get taking this COVID vaccination is because they felt that it was developed too quickly. Can you give a bit of insight on this? Do you think, that's valid? That we're all just guinea pigs,
So these vaccines have been tested in many people before it got licensed, right? So yes, we're actually glad that it's fast in terms of having a vaccine. mRNA vaccines have been sort of in the cups of being used, and I would say that, other than COVID-19, now there are other sort of mRNA vaccines as well. And I think that's going to be the future in terms of this type of vaccine. And so all the vaccines actually have clinical trials looking at side effects and all the other things. And yes, most of the clinical trials have been short term, but they have been following up patients longer term. Mm-hmm. And certainly, we're not the first country to get vaccines. And we can see sort of what is happening with other countries as well. So for us, we have had vaccines since December-ish of sort of a year ago. And so, yes, it's possible to have some side effects. So I always tell my patients that it's possible to get some muscle aches or even a fever. And but these are short-lived things. Like I would rather have that being in the ICU with a tube down my throat and, for months on end. And also have a mortality risk as well. And so you have to weigh the pros and cons for sure. But currently, based on everything that we know, I would say that getting vaccinated has way more benefits than harms.
Mm-hmm. Yeah, and I totally agree. And I would just add that I don't think ever in the history of the world has there been such a unified and concerted effort to to develop a vaccine. There's been so much international cooperation and so much money invested in this. It's a very unique situation, and one would imagine, that you would have a real accelerated output with those sorts of resources and that kind of brain power behind it. I think everyone attributes that to the speed with which it was developed. And it's been rigorously tested and continues to be followed. So it would appear to be really a very safe alternative, a very safe, very safe intervention. And when you consider the alternatives, the risk-benefit ratio is overwhelming. The benefit is overwhelming.
Okay. Someone wants to know, do you think this COVID vaccination will eventually become a yearly vaccination like we do for the flu and other vaccinations?
I would say there's a lot of discussion about that's a high likelihood situation. Yeah.
It depends on a number of things in terms of like what the virus mutates more. Yeah, there are many issues, but I wouldn't be surprised that, we will have to have repeat vaccination. The question is how often. So, for tetanus, it's every 10 years. So everything is a little bit different, and we're still learning. This is definitely evolving science, and we're keeping track of when do people lose their immunity or cannot develop neutralizing antibodies anymore, and things like that, right? So I think time will tell.
Okay. Well, I'm going to ask the audience if there are any more questions you would like to ask Dr. Herridge and Dr. Cheung. If not, then I want to thank both of doctors for coming on tonight. This has been an excellent presentation, and we hope that we can invite you to come back when your study has neared its completion and we can see some final results. And again, thank you both so much.
Thank you for having us, Sharon.
Pleasure. Thank you.